my topic is anterior ring fixation for pelvis. So this is a statement from Tiles textbook. The single most important determinant of biomechanics of pelvis is its structure, ring structure. And surgical reconstruction of the complete ring has the greatest restorative effect to give back its stability. So that is very, very important, and anterior ring is an important part of it. It can be from anterior part of the acetabulum to the pubic symphysis, including pubic rami and body of pubis. And of course, purely ligamentous disruption may also be there, which is a symphysis pubis disruption. But isolated pubic symphysis disruptions with a big opening doesn't occur unless you have a posterior element disrupted. So this is just an example of a 50-year-old man with open big kind of an injury. You can make out right SI joint is also open. So I just want to show you one video in this particular thing. So this is a video which I have taken in grass during a cadaveric course. So where a symphysis is cut and I am trying to open the pelvis, but it is not opening, right? So with a huge force, it only happens when you cut the anterior SI ligament and intraosseous ligament, then only it happens to open the symphysis. That means any big opening which has an indication for restoring stability always has a posterior component. So which is very, very important to restore while doing anterior fixation. So in this particular case, regular fan and steel incision and rectus cut and then fixed with a symphysis pubis plate. But before that, after getting anterior reduction, as I told, the posterior fixation is equally important to give the stability to the ring. It's not just anterior alone. So in this case, right SI joint which was open was also fixed, and after that come back to symphysis and fixed with a plate on the superior surface. So that is the outcome. So symphysis pubis disruption has got numerous internal fixation methods, which includes screws, wires. Although I don't have any experience with wires, and circlage wire as well as tension band wire are also described, and the plates, dual plating construct, superior plate and anterior plate. So what I feel is minimum 6-hole plate should be available, and superior has relatively good strength as it has long enough screw lengths, and both superior and anterior plating, if it is doable, then that gives more stability compared to a single plate. And this is the biomechanical study which was published in Injury, wherein tension band wiring with suture button has also equal stability in terms of anterior restoration compared with plating. So one important thing which Dr. John sir also mentioned, so by the time patient comes to casualty, most of the times there is already a pelvic binder which might have reduced the symphysis pubis. This is one particular case of a 40-year-old man. This is a CT scan. So most of the people, the CT scan is done outside and come back to tertiary referral. And if you see the X-ray, you can see the initial X-ray shows open pelvis, whereas the CT scan shows almost normal. So predicting the dynamic instability with the static image is challenging. So one has to keep an eye about dynamic stability and examine in person in the casualty itself. And it is difficult to arrive at consensus whether to fix anterior ORF for symphysis just based on the image. I would prefer to examine myself and see the dynamic stability. So that is after fixation of the same patient. Pubic ramus fracture component when it is associated with pubic ramus component, you can say this is one 17-year-old boy, met with road traffic accident. You can see left SI disruption with left pubic ramus fracture, which is displaced and hitching onto the bladder, although bladder injury was not there. And in this case, I had to use a plate. And how long the plate can go? You can go up to suprastabular area and beyond the acetabulum and then fix it. In this case, that was the outcome after an year. And the plate can go on both the sides, bridging both the symphysis when it has an anterior ring involving both side superior and inferior pubic rami and unstable. Length of plate can vary from 16 to 18 hole. In this particular case, it was a 16 hole which I've used. So in combined pelvic-acetabular injuries, something like this, the acetabular congruity is very, very important along with your stability of the pelvis. And in order to mobilize the patient also, you have to fix the pelvis, and which should even aid in restoring the congruity at the acetabulum, which needs longer plates and bridging both the side whenever it is needed. In this case, right side acetabulum was gone, and I had to put a plate from right side to left superior pubic ramus, and got a congruity at the acetabulum as well. That is a function after 8 months. The indication for anterior external ring fixation is Dr. Sunil Gavaskar has in the last talk mentioned emergency stabilization in an unstable patient with an unstable fracture pattern, and definitive stabilization in case of rotationally unstable injury where you don't have a clean anterior skin, either by laparotomy or by urological procedure. And definitive stabilization can also be done in, I'll give you one example, where unstable chair kind of an injury with significant soft tissue, moral level kind of a lesion. The external fixation can be supraacetabular pins and iliac crest pins, but just supraacetabular pins can give you a significant stability which is compared to plate itself in the symphysis. So here is a 45-year-old lady with a moral level lesion, pneumoperitoneum, and presented in shock, like it was discussed. So resuscitated and then took, as there was a pneumoperitoneum, sigmoid colon rupture, emergency laparotomy was done, and there was a anterior incision already. So I had to discuss with the gastroenterologist, surgical gastro, to place colostomy relatively superior location, but in this case I had to use a supraacetabular pin to get the stability anteriorly, which was continued for about 3 months, and that is her function after an year. So after it has healed and the colostomy is closed. The intramedullary fixation, the wide spectrum of variability between the curve and obliquity of the superior pubic ramus gives the osseous fixation pathway, which is relatively complex in case of anterior ring. And the most important views here to have is pelvic inlet view and obturator outlet view, which are important. And these are the osseous pathways through which you pass minimal invasive screw fixation. Here is a 21-year-old with a runover kind of an injury and bladder injury. You can see the CT scan. So that is with the pelvic binder itself. And the prerequisites are, radiolucent table, which is very, very important. And residual bladder contrast should not be there. And complete paralysis. These are the views which are already described by Dr. Rakesh Rajput, obturator oblique and inlet views. So this is where I had to use two 3.5 mm screws for anterior ring fixation through retrograde percutaneous screw with a small incision and posterior SI joint screw. Urethroplasty was done after 2 months, and that is after 6 months of outcome. You can see the healing of the pubic rami. And here is a 35-year-old female, ran over injury, moral levelly lesion, late presentation, and vertically unstable injury. You can see the vulval injury and perianal laceration, and all that is degloved. And in these cases, your soft tissue won't allow you to fix it posteriorly. It's only anterior fixation. Initially with the suprastabular pins, followed by once patient got stabilized and the posterior part started to heal, I had put plates. And although the reduction is not good, that is 2 years post-operative outcome of the same patient. You can see the vertical displacement, but the ring is stable and the patient is able to do her activities. In conclusion, the associated injuries dictate the approach, which is more commonly associated in case of a pelvic fracture. Almost 20 to 30% of the times you have got associated injuries, and one should know all the options. And coming to symphysis pubis, double plate has got more stability compared to superior plating, which is in turn has better stability than anterior plate. Next comes is suprastabular external fixator, and last is iliac wing external fixation. Thank you.